Good morning, everyone. And firstly, I would like to thank Professor Nilesh Mohan sir for including me in this IC. And my topic for today is epithelial thickness mapping, how far significant. And my aim for today is to convince everyone that it is extremely significant, and I hope I succeed in it. So the epithelium, as we know, along with the tear film, represents the optical interface and plays a critical role in the refractive power of the eye. The power of the epithelium alone ranges from 0.5 to 1.85 diopter at the 2 millimeter diameter zone. Therefore, small changes in the corneal epithelium thickness can cause significant refractive changes. The normal epithelial thickness is about 54 micron, ranging between 50 to 60 micron, and it is non-uniform in pattern. The superior being thinner than the inferior and the temporal being thinner than the nasal, and this is due to blinking and the friction of the upper lid, which is more superiorly and temporally. Now, what we need to keep in mind is that the epithelium is not of homogeneous depth over the Bowman's membrane. It compensates for stromal surface irregularities, becoming thicker over valleys and thinner over hills. Like this is a patient of ectasia, advanced ectasia, but over a period of time, the epithelium has remodeled itself in such a way that if we do a topography, we might just miss the ectasia. So the anterior cornea starts looking smoother on topography as compared to the underlying stroma, and therefore assessment based only on topography with no knowledge of epithelium can be misleading. So there are various tools which are available in the market to measure the corneal epithelium, and the anterior segment OCT is the most widely used because it is non-contact and very fast, and MS39 is the most recent one with the highest resolution. So ETM has multiple applications. It is an additional tool for early detection and monitoring progression of ectasia and also for following up post-C3R patients. And it has a very important role post-refractive surgery in managing post-op refractive surprises, preoperatively for safer screening, and also in the surgical planning of transepithelial surgeries, LASIK flap depth, and enhancements. So in keratoconus, what we have is a localized zone of epithelial thinning, which can be seen here over the cone, and this is surrounded by an annulus of thickened epithelium, and this is the classical donut pattern. Epithelium is highly irregular in keratoconus with very large map variations, and point over the cone being up to 30 microns thinner than the thickest point at times. Now this is a patient of keratoconus with a scar. So there is thinning of the epithelium over the cone, but in the center where the scar is present, there is thickening of the epithelium, showing that if a thin area is flat, like a scar, the epithelium will thicken over it, proving that the epithelium responds more to the underlying curvature and not to thickness per se. So ETM also helps in distinguishing ectasia from pseudoectasia, which is extremely important from a refractive surgeon's point of view. Pentacam will show steepening in both warpage and ectasia. ETM will show maximum epithelial thickness corresponding to the steepening in warpage and maximum epithelial thinning corresponding to the steepening in ectasia. Now this is a patient of a contact lens wear who is using contact lens only in the left eye for the past few years. So the right eye is absolutely normal topographically and the ETM is also absolutely normal. But the left eye is showing elevation in the anterior curvature map, and the epithelium thickness profile in the left eye is showing generalized thinning and thickening over the central region corresponding to the elevation, enabling a diagnosis of contact lens warpage. It's extremely important in screening patients for refractive surgery, and studies have found, very interestingly, that larger patients are screened in with the epithelial maps then screened out, and this is because pentacams tends to overdiagnose keratoconus and gives false positive results. So this is a suspect case with a steep K of 49 diopter and a total D of 2.1. But the ETM over here is showing very regular epithelium with no areas of thinning. So the patient was confirmed as normal on ETM and screened in. This suspect case has a thin cornea of about 450 micron and a total D of 2.1. So here again there is no thinning in the epithelium. In fact, there is thickening of the epithelium in the center, and this patient was also confirmed as normal and screened in for surgery. This patient had a Kmax of about 49 diopter and a total D of 1.7, which is borderline. But the ETM here showed the classic donut pattern which is seen in keratoconus with thinning surrounded by thickening. So the patient was screened out, confirmed as keratoconus and screened out. The other eye of the patient, which was absolutely normal topographically, was also showing irregularities in the epithelium. So post-refractive surgery, it also helps in differentiating between early ectasia and regression. In ectasia, there will be thinning over the steepest portion of the cornea, while in regression, there will be thickening in the central zone corresponding to the flattened area post-refractive surgery. And it also helps in monitoring post-op changes, and this is extremely important when you have any post-op refractive surprises. So post-surgery, the epithelium remodels in response to both curvature and thickness, thickening an area where curvature has been flattened, and thinning where it is steepened, and also thickening to compensate for the stromal tissue loss. What we need to remember here is that epithelial thickness increases proportional to the spherically equivalent corrected. The response to curvature is more than the response to thickness, and it does not usually affect the visual outcome. So these are a few post-LASIK ETM maps. In myopia, you will find thickening in the center corresponding to the ablated zone and thinning in the periphery. And in post-hyperopic maps, you will find thinning in the center corresponding to the area which has been steepened and thickening in the periphery. Irregular epithelial remodeling can sometimes be seen as an atypical response to surgery due to some interface of flap complications or due to epithelial abnormality. And these atypical responses can sometimes lead to regression, unstable refraction, and diurnal fluctuations in the vision. So this is a patient of a post-op refractive surprise who presented to us about a month after LASIK with a sphere of -1 in the right eye and a cylinder of -1.5 in the left eye. The ETM showed generalized hypertrophy of the epithelium in the right eye and abnormal focal regions of epithelial modeling in the left eye. So the patient was put on medical therapy with steroids and anti-glaucoma medication, and they typically respond very well to it. At the end of 1 month, the epithelium had regularized and the patient had regained a vision of 6/6. So here again, we need to remember that the largest epithelial response takes place only in the first month, and the earlier these atypical responses are picked up, the better they will respond to therapy. This is a post-hyperopic LASIK patient who presented with aberrations, glare, and diurnal fluctuations. The ETM showed a lot of irregularity with fracture lines. This patient was also put on medical therapy. The epithelium remodeled, and the quality of the vision improved by the end of 2 months. Post-LASIK DLK also shows a lot of irregularity, and the good news is that this also responds to treatment, though it might take a little longer time than the other cases. Post-PRK remodeling shows increase in the central epithelial thickening in the post-op phase, and this typically stabilizes by the end of 6 months. Increase in the central epithelium, the long-term comparison between LASIK and PRK does not show any difference in the epithelial remodeling, and it does not really affect the vision. Post C3R, ETM is the most sensitive method to monitor progression. This is the patient of keratoconus showing thinning over the cone area. 6 months after C3R, there's a lot of thickening, but still a lot of irregularity. But by the end of 9 months, the epithelium has smoothened out and there is thickening of epithelium over the cone region. You can compare it with the pre-C3R map. So this is very nicely smoothened and thickened out, and this indicates a successful treatment. In cases of failure, the ETM will continue to thin out. Now this is also very important in planning refractive surgeries, and the rule that the epithelial thickness is 10% of the total corneal thickness does not always apply. Here we have a patient with an absolutely normal topography with a very thick epithelium of 120 micron. And here you have a patient with a normal topography with very irregular thin epithelium due to dry eye. So inputting arbitrary figures and planning procedures without epithelial mapping can lead to refractive surprises, suboptimal results, and flap-related complications in LASIK enhancements as well as PRK. So this is also very helpful when you're trying to customize treatment, especially in cases of keratoconus, when you're trying to plan a TREC or a TCAT, when you need to identify the epithelial thickness on the thinnest location to plan the treatments. Like this is a patient of keratoconus with the epithelial thickness of only 20 micron over the cone. So this is highly significant when you're trying to plan some treatment. And also in PTK cases, when you're trying to treat corneal irregularities or any post-LASIK flap complications which you want to smoothen out by PTK, you need to know the exact epithelial profile and the thickness in order to get optimum results. So to conclude, epithelial thickness mapping is an important tool in the refractive surgeon's armamentarium, and it has a role in the screening, planning, and post-op evaluation in refractive surgery, but interpretation should always be made in context with the clinical findings and topography. Thank you.
Thank you, Dr. Gayatri. You very crisply explained the importance of epithelial mapping. But one thing I would like to just ask, ma'am, if you're doing a PRK and you don't have an exact epithelial mapping, can you proceed with a safety? I mean, post-op response after PRK in the initial days shows an epithelial thickening. Later on, it gets remodeled. But can you move ahead with a standardized?
So the best thing is to have an epithelial thickness map, but many cases will be okay because mostly it is around 10% of the total corneal thickness. So you will be fine in most of the cases. But there will be a few cases which will surprise you. So it is always good to have an epithelial thickness mapping with you.
So, thank you, ma'am. Definitely, your data have definitely suggested that. I mean, it would be definitely a more accurate tool when you are going ahead with your epithelial mapping.